I want to get now just want to get your opinions a little bit on the differences between these drugs, because now we have three drugs in the same class, and obviously you're only going to pick one, and we don't have head-to-head data comparing these drugs, and we may not for a while. How do you decide which agent to use? Are there real biologic differences between these drugs in terms of their pharmacology or biology that would influence where who you might prescribe one to another? Eleni, any thoughts on that?
So this is a great point, because I think we would all agree, for the purpose of not going into a lot of details, that we're looking at a class of agents that have a very similar efficacy across the board. I mean, you can have your personal preference, and then it boils down to how are you going to adapt it in your clinic, and you would like to be equal in giving all three a chance to see how it works. And this is an important thing to take into consideration. I'm in an everyday practice, not an academic practice, and I'm going to reach for what I know how to use, right? And we know that one of the three drugs has been around forever. Ben will speak more to it. But we've got a newcomer in here that is actually has, in my mind, clearly proven from the preclinical data and ongoing that it does not pass the brain barrier. So that may give it an advantage, because we all have to admit that the other two agents, meaning enzalutamide and apalutamide, do pass the brain barrier. Maybe apalutamide not as much, that is debatable. Maybe the fatigue ensuing from there is less, but then you get a little bit more of the rash coming in that has been a nuisance for some of the practitioners. So it all boils down essentially to safety. So now you have one agent that's been around for almost 8 years now, and two that are newcomers, apalutamide and darolutamide. And I can tell you, I have not used darolutamide a lot. I just started the moment it got approved, right? I haven't done any research on it, I'll be honest. Other colleagues have. And I have limited experience to date, and it has been positive. It lives up to the claim of not having as much of fatigue. Now, if you look at the three trials, and don't focus a little bit on the little details, how much fatigue here, how much fatigue there, but look at the differences of discontinuation due to adverse event versus placebo, right? That's your comparator in each one of these trials. You'll see that you do get that difference in percentage in the Spartan trial, which is the apalutamide one. You get the same difference in the Prosper trial, which is the enzalutamide, but there is no difference between the darolutamide arm and the placebo arm when you look within Aramis. It's about 8.5 discontinuation due to adverse events, which in this case are obviously more associated to potentially disease progression and maybe a little bit of darolutamide there. But as an overview, until we all get more hands in using it, I would say that this data would actually convince me to reach out to try more of the darolutamide agent, especially in my older patients who, as you said, are this group right there. And you want to make sure that they're not going to have more falls, they're not going to have more instability in their gait, more if they have also some backbone of neurologic deficit there. So I'd like to hear everyone's thoughts on that.
Tanya, I see you nodding your head. I mean, is this your way of thinking as well?
Yeah, I will say that the treatment discontinuation rate is a good tool to judge how much your patient is going to struggle with side effects, right? How often do they get bad enough that they're going to stop the treatment? And there is a difference, I would say. My own experience, the darolutamide is very well tolerated. I don't see some of those CNS type effects that I see with the other agents. Not to say that apalutamide and enzalutamide are not well tolerated. They really are. And the quality of life data, again, speak to that. But I agree that darolutamide not crossing the blood-brain barrier is significant. In my own practice, it's not just cognitive, but it's also sometimes a little anxiety or depression or just this ill feeling, right, that can lead to discontinuation. And I take that to be a CNS effect. Importantly, there are ongoing prospective formal studies to look at cognitive changes. And so eventually we will have level 1 evidence that can really guide us when we're concerned about that particular aspect of toxicity.
Are there ways to quantify this kind of stuff? And is there Are there things we could be
Absolutely.
doing in our practice to kind of recognize when maybe this is a risk in our patient population?
Absolutely. And I think this is where we need to learn from work that's being done in the field of geriatrics and neuroscience. There's a lot of tools available to look at cognitive function. Whether we can integrate those into a daily practice in an oncology or urology practice is another question. Fall risk is something that has been associated with a couple of these drugs. Assessing the risk for falls is actually quite easy to do. There are validated, the timed up and go test is very easy. Anybody can do it in any clinic, anywhere, if they know what they're doing. It's just actually having a person walk, 10 feet and back and timing that. And so I think that we need to get the word out about these tests, provided that we think there is a significant difference between the drugs. And I think building on Tanya's point, we have to do those studies prospectively, look at whether there are differences, and if there are, and all drugs are still, or all the therapies are still available, then we make those tests available. We teach our field how to do those tests so that they can use them in their decision making. It's really no different from using a genomics test, if you will, to make an action.
I mean, even if there's not a huge difference between these drugs, even if it's a class effect, I think it's important for us to recognize it, because it would factor into, our management decisions in these patients. But if there are differences by drug, well, that's even more important to know going forward.
And as our patients are living longer, as we just got done saying, and that maybe their risk of dying of prostate cancer is slowly getting away as we give better therapies, attention to these types of factors is more important.
Right. I was just going to say that because it is a class effect, and because they're still on hormone therapy or castration therapy, paying attention to what we can do to mitigate any potential fall risk, for instance, it is important. So I think talking to patients about the importance of exercise, making referrals to physical therapy when appropriate, is really part of our job as we're using these agents earlier and longer.
And prove to the payer world that these things are worthwhile to do and should be covered.
Yes.
And I think, from the not having the internal medicine background, encouraging our teams to be looking into cardiovascular risk and risk of metabolic disease and other, other things that we know that these agents all can contribute to, is all part of the same thing. Falls and fractures are the dramatic events that we know we need to avoid. But, just because more patients are dying of cardiovascular disease doesn't necessarily mean that it's not related to their prostate cancer, since we're using these agents. So, I think understanding that we have to incorporate all of these risk assessments into our practice is definitely a focus.
Huge point.
I think I want to make that comment, Ben, for you mainly, because I think it's a matter of streamlining it and building an algorithm. Like, you guys are urologists. You don't have the time to mess with that. You want to have, though, an algorithm where you send the patient to the cardiologist for his checkup, do the bone density. I mean, breast cancer has done it. Do that bone density every couple of years, assess the risk factor. You don't even have to do it. But if it's built in the algorithm, checklist, we do it.
That's exactly what we're trying to do. Yeah.
I mean, it's really survivorship, right? And it's building in that survivorship model in these patients. No, they're not cured. They're but they may not die from prostate cancer. So these are the competing survivorship issues that we have to balance. I mean, I thank you, Ben, for bringing that up. I think it's a great perspective for urologists, and I like that analogy, Eleni. I think we can do this in our field as well.